Okay, all right. Well, welcome everyone to our speaker series, the next in our continuing speaker series. My name is Chris Hobson. I'm the Chief Medical Officer at Orion Health. Today, we're very excited to welcome our friends from the Canterbury District Health Board based in Christchurch, New Zealand, for the next edition in our speaker series. Carolyn Gullery. Carolyn is the Executive Director, Planning and Funding at the Canterbury District Health Board and the West Coast District Health Board in the South Island of New Zealand. Carolyn will share her story of how her organisation was able to shift care delivery from the acute setting to the community in a significant way with some help by and from Orion Health. Welcome, Carolyn.
Thank you. Kia ora tātou. As Chris has said, my name is Carolyn Gullery. My role is the Executive Director of Planning, Funding and Analytics for the Canterbury and West Coast District Health Boards in New Zealand. And thank you for this opportunity to talk to you. I'm just going to take you through our story about how we have, over the period of time from 2008 to now, built an integrated health system and how important it is to have the data and the ability to link up a system. I would argue that one of the things that has made our system successful is our ability to communicate across our system using our IT infrastructure and use our data and use that to drive service change. So I'm going to start at the beginning, just to give you a bit of a sense about the Canterbury District Health Board. But before we go any further, this is how we see our system. We see our system as a system that puts people in the centre, that designs a system that seeks not to waste their time. So we're trying to build a connected system centred around people that aims not to waste the time of our people. And we visualise this in this diagram here, and you can see right at the centre of our system, I can introduce you to Agnes. Agnes is the person that we put at the centre of our conversations, because when we started our journey, the biggest issue that we had to deal with was our ageing population and the needs of that population, which are overwhelming both our hospital-based system and also our long-term care facilities. So think about Agnes as we go through our system. Context. Excuse me, first thing in the morning. Context, second largest district health board by population in New Zealand. So essentially we currently have about 578,000 people living in Canterbury, but we are also the tertiary provider for the whole of the South Island and the lower part of the North Island in New Zealand. So we're the second largest tertiary centre in New Zealand. We employ close to 11,000 people. So we are the largest employer in the South Island and probably the 10th largest employer in New Zealand. This is what an average year in Canterbury looks like. So 123,000 people go through our hospitals. We have 6,000 babies born, and we have about 5,000 people living in aged residential care. As a district health board, we're accountable not only for running the hospitals, which we own, but we also fund the entire health system. So we provide the funding for primary care, for community-based services, for the non-government organisation sector, and for long-term care for the elderly. So I'm going to take you a little bit through the numbers first, because analytics is my thing and I like to start with the numbers. Since we started our journey in 2006-07, this is what's actually happened to our population. So if you got this in your head, you understand that since that 2006-07 time, our population's grown 91,000 people. The Māori population in Canterbury has grown about 20%. So Māori, being the Indigenous population in our country, normally has poorer health outcomes. Also, the population over 75 has grown 20%. So like all Western world populations, we're seeing an ageing population. So this is just so you understand that from when we started this journey, we had 65,000 people over the age of 65. We now have 94,000 people over the age of 65. Those numbers will become important when you have a look at what's happened in our hospital-based system. What we set out to do was bend the curve. We set out to recreate a health system that kept people well and healthy and in their own homes. So to give you a sense of whether we achieved that, So in Canterbury, we have an ED attendance rate adjusted for age of 188 per 1,000 people, which compares to the New Zealand rate of 239. But more importantly, you can see the people over the age of 65, we have consistently kept their rate of attending our ED at a much, much lower rate than the New Zealand population. And New Zealand does pretty well in terms of avoiding ED attendances, and actually better than, for example, Australia or the United Kingdom. So being lower than New Zealand makes us lower than anywhere in Australia or the United Kingdom. In terms of acute medical admissions, we've managed to twist a system so that we keep people well and healthy and in their own homes. We look after them in their own homes when they become unwell. So we've been able to avoid hospitalisation, and our acute medical admission rate is 27% below the national average. That actually has meant that since 2006-07, we've actually managed to pull down our acute medical bed days. So despite that growth of 91,000 people in our population, we're actually using less acute medical bed days than we did 10 years ago. And we'll come back to that in some comparative data. The way we do it is we use data. We use data for service design. We use the data to analyse what it is that we can do better and how we can improve. So one of those programs, for example, was chronic obstructive airways disease, which is a big driver of hospital attendances in Canterbury. And what we've managed to do by using the data, understanding how patients flow through our system, and doing what we do in Canterbury, which is get everybody in a room. So we got the ambulance service in the room, we got general practice in the room, we got the consumers in the room, we got the secondary care clinicians in the room. We looked at the numbers and said, this isn't good enough, we must be able to do better. We realised that in the middle of winter, we were using 2 wards in our hospital to look after people with chronic obstructive airways disease. And of course, we don't really make any difference to their outcomes in a hospital. So we thought, can we do better? And we did. So when we started this journey, we were using about 8,500 bed days per annum of people in our hospital. We're now looking at about 4,500. So we almost halved the number of bed days that people with chronic obstructive airways disease spent in our hospital. Did the same thing with falls in a community. We're no better than the rest of the world at preventing people from falling in our hospital, but we have actually figured out how to stop them falling in the community in the first place. And that was all part of our long-term plan to keep people well and healthy and stop them ageing and ending up in long-term care for the elderly. We recognised that if frail elderly people end up in our hospital, then their chances of ending up in long-term care went up significantly. So we do everything we can to keep them out of hospital, and one of them is to keep them on their feet. So we have a community falls prevention program, which in the space of 7 years has led to 3,000 fewer ED attendances, but more importantly, nearly 1,000 fewer fractured hips. And what we've managed to do by actually managing our hospital-based system better is reduce the amount of time that people who do fracture their hips spend in our hospital, get them home faster, rehabilitate them at home and not in a facility. And the consequence of that is that we've seen a reduction in the rate of death post-fractured hip at 180 days. So not only are we keeping them well, we're keeping them healthy and we're adding to their length of life. There's some other things that we measure which are all predicated on our ability to manage the information and the data. I mentioned the Māori population, which has poorer health outcomes in New Zealand, which is not as the same around the world, but we've been focusing on that in our country, but particularly in the South Island. And what you'll find in Canterbury is that Māori are less likely to end up in our hospital than even non-Māori in the rest of the country. We also have reduced the mortality gap. So in New Zealand, Māori die about 7 years earlier than non-Māori on average. In Canterbury, it's 2. And we've closed that gap between 2013 and now. And if we keep on closing it at the same pace, then in 15 years, we will have got rid of that equity gap in mortality for Māori. One of the things that we set about to do when we organise this system is also keep people allow people to die in the place that they'd like to die, which actually for most people tends to be their own home. And we achieve this through our electronically shared advanced care plans. So I'll talk about in a little bit about how we use Orion's Concerto as the platform for our connected health system and our shared health record. But one of the things that gets shared on that system is the advanced care plans. And because they're electronically shared, it doesn't matter where you turn up in the Canterbury health system, a flag will come up telling you that this person has an advanced care plan and what their wishes are at the end of their life. Since we implemented advanced care plans in an electronic way across our system, we've gone from 32% of the people over 75 who die in any 1 year dying in our hospital down to 26%. And we're seeing a constant continuous improvement. Interestingly enough, in the recent COVID lockdown, advanced care plans and acute care plans, all of which are shared electronically on our systems, accelerated as general practice had time to work with the community on how it is they would like to have their final days. There's a whole lot of other measures of performance of a health system. Immunisation, breast screening, cervical screening all tell you when a primary health system is working particularly well. But one we're really proud of is the faster cancer treatment. When we started this journey back in 2006-07, Canterbury was the worst performer in the country. You were more likely to wait longer to get access to cancer care. You were more likely to wait longer to get access to radiation therapy. Now you can see that in Canterbury, 98% of the people get their way through our pathway within 62 days. So we now have, using our systems and using our data, improved the outcomes for people with cancer in Canterbury. It's probably just as well because we have the highest registrations for cancer in the country, but it's good to see how you can actually improve a system. And a lot of that was about getting rid of the lag, as people literally inside a hospital sent letters to each other. And now we're using our electronic systems to actually map out a pathway for our patients. I keep on talking about what we set out to achieve. We actually had a plan. We had a vision for 2020. And we developed this vision in 2008. And it was a vision for an integrated Canterbury health and social care system. And it's actually that strategy that has driven our system for the last 12 years. Because what we did is we sat down back then and we said, if we keep on doing what we're currently doing, then by 2020, we're going to need 400 more hospital beds, 2,000 more long-term care beds for the elderly, and 8,000 more people in the health workforce. And that's what galvanised the system to realise there had to be a better way. And so we started our journey to build that connected system centred around people that aims not to waste their time. And we use time as our unifying metric across a health system because we can measure that. Everybody can measure time. And it's about making sure that at every step in a patient's journey, from the community through primary care into our hospital-based system and back, is as timely as possible to make sure they have the opportunity to live their best possible lives. So back to those populations. When we started this journey, we had 479,000 people in Canterbury. The projection was that by 2021, we'd have 532,000 people. In reality, by the time we hit 2018-19, we already had 578,000 people. Our population grew a lot faster than we originally projected when we did those projections about the number of hospital beds we were going to need. And that was largely because of the Canterbury earthquakes that happened in 2010-11, which completely changed the demography of Canterbury. But fortunately, we had our vision, we had our plan, and we had our strategy. And what we did is we just made it all happen a lot faster. What you can see in this graph is also that where the big population growth has been in the 20 to 30-year-olds, and that will become important when I show you some of the next data. So in terms of discharges from our hospital for people over the age of 15, you can see how those 20 to 30-year-olds spend a lot of time in hospital. But you can also see that what's happening for the over 70s and the over 75s, which was the big focus of our strategy. So yes, our number of discharges have definitely gone up. But and they've gone up in that younger age group. But where we set out to achieve a significant change, because we understood that if our frail elderly population ends up in our hospital, then the chances of them ending up in long-term care for the elderly goes up. You can see how much less we have had frail elderly people in our hospital. So against expected, 2,000 less discharges for people over the age of 85. So what we've got is admissions are lower than expected for older people, but higher than expected for younger people. But younger people have a shorter length of stay, and it largely reflects the way that our system now works with emergency observation in our ED, where we can keep younger people for a very short length of stay without actually admitting them to our hospital, but we still count that as an admission. So what's the total impact on bed days? Well, interestingly enough, on average, our population over 15 in 2008-9 used 1 bed day per person per annum. It's now 0.7. So we literally have had a 30% reduction in bed days per capita in Canterbury since we started our journey. In terms of occupied beds, our population between those two timeframes from 2010 to 2018 has grown 12.1%, but our occupied beds have fallen by 1.8. It's probably just as well, because we have less acute hospital beds now than we did in 2006-07 when we started this journey. And that's because we lost a few in the earthquake and they have yet to be replaced. So if we hadn't got better at managing patients in our hospital and keeping them well and keeping them out of our hospital but getting them home faster, we would have had a significant problem. I talked a lot about age residential care, which is really important for a number of reasons. First of all, people in Canterbury ended up in long-term care for the elderly more often than they did in any other part of the country, and for longer. And part of our value as a health system is we don't believe that we want to institutionalise our ageing population. So what we've done is we've reversed that trend, and in fact our total bed days in long-term care for the elderly has decreased by 15% since we started this journey. That is despite the fact that that population over 65 has gone up from 65,000 to 94,000 in that same time frame. So more people over the age of 75, a 20% growth in over 75 population, but less likely to spend time in long-term care for the elderly. The one thing that we haven't been able to tackle is dementia, and you can see our dementia bed day rates have increased by 30.5%. So that's an international problem, and we haven't found the solution to that one yet, and why we end up with so many people with dementia in long-term care. But that's the next step in our journey, is to solve that particular issue. So we set out to change the system by 2020. So what's actually happened? Our population's grown faster than expected, but they're less likely to be in a hospital bed. They're supported to manage their own health. Our primary and community services are managing people better in their own homes, and our hospital services are more efficient, and people are spending less of their lives in aged residential care. We actually met pretty much all of our targets, and we haven't got those 400 extra beds. In fact, when our new hospital, which is replacing the hospitals we broke in the 2010-11 earthquakes here in Canterbury, which will be opening, we hope, in a couple of months' time, will only add 30 beds to our entire bed numbers here in Canterbury. So rather than needing those 400, here we are with a population significantly bigger than we predicted, and yet we don't need the same number of beds. Now, we've all been through some interesting times, and you will be aware of the fact that New Zealand has taken a particular approach to COVID-19. So I just thought you might be quite interested in seeing what happened here. So what actually happened with COVID-19, this is the ED attendances for people over 65, which you can see we've been consistently keeping much lower. They dropped right off as we hit the COVID lockdown. And that's the rate, even the rate of attendance has dropped off, so it wasn't just the number. And what you'll see here is, and I'll just blow this one up for you, our non-COVID admissions, so our admissions to hospital for people who didn't have COVID-19, because we only had a very small number of people in our hospital who did, dropped well below projected. So those dotted lines reflect our projected, based on predictive analytics and us knowing who's going to arrive in our hospital. And you can see from the time that the lockdown started in March, we had a significant drop-off in people over the age of 65. But what you'll all notice is that when we came out of lockdown, people over 60 kind of reverted back to the mean. But what we saw with the under 60s is not only did they drop off in terms of their admissions, they also didn't come back to the mean quite so quickly. And you can see certainly here the ED attendances for the people under the age of 60 just dropped away, very much lower, more than 100 less people a day arriving in our emergency department. What that's meant is we can, because we're comparing what we did last year with what we did this year. And what it meant was that over that time frame, when New Zealand was in lockdown, we saw 5,500 less people in our hospital-based system. But they were made up of a mixture of acute admissions, which were sitting at about 3,000 acute admissions that didn't happen, but also elective admissions. So the planned care, which is that red line that you can see there. So what you can see is the big hit was actually acute admissions. It's people not becoming acutely unwell. And the big drivers for us were cardiovascular disease and chronic obstructive airways disease. So it turns out, unsurprisingly, that if you keep people isolated in their own homes and not meeting other people, that the circulating viral load drops and people don't get exacerbations of their congestive heart failure or their chronic obstructive airways disease. It may be a new solution to our all collective winter challenge. Now, how did we do all this? What we did is we built a platform, and you can see that information and shared information is a core part of our platform. So we had that shared vision of a connected system centred around people that aims not to waste their time. We have empowered networks, which are clinically led local and regional alliances, which are our vehicles for implementing system change. They're built in a high trust, low bureaucracy type model, and a basic belief that there is only one health system. There is actually only one budget, even though multiple people fund a health system. If we all behave like there's only one budget, and we all focus on balancing what's best for the patient in front of us with what is best for the system, we can make significant change. And the other big mindset was the idea that everybody wins together. So we moved away from any thought of competition or financial incentives or any of those kind of models and got into a model of collective impact. And it's based on the idea that clinicians are trusted, care pathways are redesigned, then you reorganise your funding and resources to support them. You have the patient or the person in the middle of that process. We do know that it responds really well to external shocks because, unfortunately, in Canterbury, between earthquakes, fires and mosque attacks, we've had plenty of opportunity to test it. And this is really what adaptive leadership, as you'd read about it in the Harvard Business Review, is really about. This is about empowering your whole system to do it well. But to do that, you do need your information architecture to work. So this is about supporting people to stay well in their own homes and communities. And we do it through a number of elements. One of them is co-owned coordination. It's the way we do it around here. So we use clinical pathways. We have a product that we've built ourselves called Health Pathways, which is designed and developed in Canterbury, but is now used actually in 47 health systems around the world, supporting nearly 35 million people. It constantly grows, which is why this slide is behind. So these pathways provide a standardised model of care for patients, but it's not a prescriptive model, it's a standardised model. It's designed to help. It's regularly reviewed by clinical teams. And 99% of our general practitioners will look at health pathways this week. 70% of them will have looked at it today, just to help them understand what resources are available for them in the system to look after the patients in front of them. We have a number of other things that go with it. So we have health info, which is for patients. We also have a program called Leading Lights, which is actually designed for schools. And that does exactly the same thing. It gives teachers the guidance they need to look after the student in front of them in the best possible way. We redesigned a number of pathways in Leading Lights over the weekend, from the mosque attack on Friday to school opening on Monday, so that the teachers had the resources they need to look after the mental health and well-being of the class in front of them. We also link this all together with a shared orientation. We have an outcomes framework, which is a combination of an outcomes framework and a strategic plan on a page. So this is not only what we're trying to achieve as a Canterbury health system, but it's how we know we got there. So we have a number of system level measures: decreased institutionalisation rates, decreased adverse events, decreased avoidable mortality, and then that breaks out into another series of measures that help us know if we're going in the right direction or the wrong direction. So this holds the entire system together and helps everybody understand if they're doing the right thing. We've got a lot of services that support people in a community-based setting, and our general practices are enabled to do everything fully funded by the district health boards, such as order, access to MRI scans, all on a pathway that's been agreed between them and the hospital-based clinicians, so that we know that wherever you turn up in the Canterbury health system, you'll get the same response. And underpinning all of that is the information technology to support it. So we have a shared health record called Health One. It's platformed off Concerto, which we refer to as Health Connect South, because it's the one single clinical record system that runs across all of the hospitals in the South Island, not just all of the ones in the Canterbury District Health Board, which means wherever you turn up in the South Island, people can see your information. Health One brings all of the information in general practice, the community organisations, pharmacy, into that same portal, so that as a health system, we can, wherever you turn up, whether you turn up in our emergency department or you arrive in our after hours care centre in the community, everyone can see everything they need to see to provide you with the best possible care. And as I said, it's all about the data, a single source of truth. Pull all the information, all of the raw data off all of our systems into a data warehouse, because quality data leads to better analysis. And better analysis drives insight, and greater insight drives behaviour. So we look at data in three ways. We get the clinical care of the patient. So what do our clinicians need to know right now to enable them to provide the best possible care to their patient, wherever that clinician is across the Canterbury community? Then we use data to drive the operational decisions. How are we managing and running our hospital? How do we make sure that we've got beds when we need them? How do we juggle in a constrained hospital that, despite our best efforts, is still running at very high in terms of its capacity? That's real time, and again, we pull that straight off the systems and display it back in dashboards. And then the last one, which of course is at the heart of what I do, is using that data to plan services, using that data to redesign, using that data for improvement, making sure that we can forecast exactly what needs to happen in our system so that we can have our resources deployed in the right place. It's clinically led, so the data is made available for the clinicians can see it and they thrive on it. We have dashboards that we pull off our systems that make it possible for our patient flow manager to run a complex network of hospitals. We've got over time, we've got our clinicians so used to using data that when we made the transfer to SIPICS, which is the South Island Patient Information Care System, which is again another Orion product, when we made that switch, the data was down for a little bit as we had to rebuild all of our dashboards, and all of our clinicians complained because they couldn't see. And they felt like they'd actually been blinded because they couldn't actually see the data in the way that we've been providing it to them. So as I said, data is really the kind of lifeblood that flows across our system that keeps it connected. We believe in the data, we use it to shape our destiny. It makes it, because it's readily available across the system, it enables collaborative ways of working, and it means that our clinicians are constantly driving to do better. So across that, as I said, we've got Health One, which is built off Concerto, which enables us to connect up an entire health system. We have the Concerto, which we call Health Connect South, and we have the South Island Patient Information Care System, which is the operational system, that patient management system that all big organisations need to have, which manages the flow of patients through our hospitals. We also have a number of other systems, and that's one of the things about working in this way. We connect in lots of our products into our system, and we integrate them seamlessly thanks to the work that we do with Orion, which enables us to actually take best of breed and connect it all up. We also have the ability to combine both our structured and our unstructured data. So we pull the data off Concerto into our data warehouse, and we use it as part of our analytics. And that means we've basically got data warehousing, health pathways, which creates the framework upon which the system works. So we have both community health pathways and hospital health pathways, but in the background, they're actually the same. And then we have our electronic health record, which enables us to do things like share acute care plans, share personal care plans, share advanced care plans. And then we have persistently and expandingly SNOMED-enabled technology, which enables us to get even more out of the data, out of what clinicians write, not just the actual transactional level data. So we use pathways to standardise our workflows. We bring all of the data across an entire health system, so including primary and community, into a data warehouse, which enables us to then not only report to the ministry as we need to, but also provide all of that information. We use Health One to share records. It's got shared records and shared planning for over 1 million people. And we also have an electronic request management system that again works across the entire system and empowers communication between all of our providers in our system, so that patients can be referred with the right information and we can see it. So we can track that referrals through our system and know not only what it is that we did do, but also what it is that people needed us to do. So where are we going? We're on a journey to a new future, which is constantly improving and changing. In fact, by releasing data across our system, what we end up with is clinicians who are constantly chasing how could they do things better. And as we all know, there's new data coming. So we've got our current data that we all use, our electronic medical records, our radiology reports, all of those things that we have now in our systems, and we are able to make visible to clinicians, and we are able to use to plan and organise our system going forward. I mean, it's always been a challenge in health that the data is in multiple systems. It's not normalised. How do you bring it all together? There's that. And then going forward, the structured data for things like genomics is going to be enormous. We've always failed until recently to use the unstructured data. There's so much richness in the notes that clinicians write, but we've been able now to start to touch that and bring it in so that we can use those clinical records to again inform what it is that we're doing. So we've actually been able to use things like machine learning over the structured and unstructured data. We've got predictive analytics that uses statistical process control to forecast the future. It enables us to do things such as every morning when patients arrive in our hospital, there's a report that's delivered from that pharmacist prioritisation report you see in the bottom of the screen. What we do is we take the data in Health One. We know that Mrs. Jones arrived in our hospital. We can take the data in Health One. We can see what pharmaceuticals she's currently on, and then we can deliver according to an algorithm, a list for our pharmacists in the hospital of who are the most important people to see first, so they can prioritise their workflow. So this whole journey has been about collective impact. It's about getting a shared understanding across an entire system about what the problem is that we're trying to solve, and then working together to solve it. So if you bring it all together, it's our health system, the Canterbury health system. We're all going in the same direction, keeping Canterbury people well and healthy and in their own home. We can reinvest and disinvest because we can all see what's going on. We have shared insight and learning. It's available to everyone, because information that's not shared is not powerful. You have to share information for it to work. We have a co-owned coordination model where we all agree what the pathways are that we're going to use to support our people in our system, and we have high trust data integration. You bring all of that together, that's how you can actually drive a health system to a different future. A couple of final thoughts. It's a way of working. It wasn't laid out in a Gantt chart. It wasn't a project. It was a direction. It was a way, it was a whole of system approach. It engaged everybody across our system, including our people. It drives change based on the best care for the person in the context of their family or whānau and their community. And it works irrespective and despite the structures. So it won't matter if the Canterbury health system is restructured and we don't have district health boards anymore, we have something else, which is entirely possible, because actually our clinical teams are used to working this way. This is the way they want to work. And provided you've got that lifeblood, which is the data and the integration of information systems across a system, then actually this thing survives any structure. It will continue to adapt and evolve, because that's the power of having that information available. One of my favourite quotes was from Margaret Mead: "Never doubt that a small group of thoughtful, committed citizens can change the world," because indeed it's the only thing that ever has. So this is the power of actually harnessing the people on the front line, the people who do the work, the population of Canterbury, people working together, giving them the information and the support they need to make a difference in their lives. And must finish with a very well-known Māori quote: "E aha te mea nui o te ao." What is the most important thing in the world? Hei tangata, hei tangata, hei tangata. So whatever you do in any system, anywhere in the world, it's always ultimately going to be about people.
Thank you so much, Carolyn. That was just excellent. On behalf of Orion, we really appreciate you joining us today and sharing that excellent presentation around the journey that the Canterbury District Health Board has taken. I don't see any questions, but if anyone has one and they'd like to share it, please feel free to add it into the Q&A. Otherwise, we will, you can feel free to send it through to myself, which is Cara Hill, my email, and we'll be certain to get you connected with Carolyn. Okay, I don't see any questions there, so I think we'll end that here for today. Again, Carolyn, thank you so much for joining us. We really appreciate it.
Thank you, Gary.
All right, you take care. Thank you.
Thanks. Bye.